Well, good morning, everyone. Thanks to the organizers in the first place for inviting me. Thanks to the City of Houston for its resilience to move forward with this meeting, and I wish you a rapid and complete recovery. So Tim really said that the new therapeutic options are actually more on the non-therapy side, so I will have a little bit to cover, but this is really the most exciting development at the moment. So just to remind everybody that this landmark analysis of the IRIS study at 10 years really sets the benchmark, 83.3% overall survival at 10 years. This is where we have to measure every other treatment against. Mike Morrow already showed this slide. So CML survival nowadays is really driven by comorbidities. I think, if we apply the available treatment and monitoring tools to the best of our knowledge and according to guidelines. And number three, there's a current spectrum of Abl kinase inhibitors, and there are two that I'm going to talk in a little bit more detail. One is bosutinib in the front line, and the second one is asciminib, which is an allosteric inhibitor that is currently in phase 1/2 clinical trials. The first part of the talk is dedicated to bosutinib versus imatinib comparison, phase 3 trial that tested 400 milligrams of bosutinib versus 400 milligrams of imatinib once daily. You know that bosutinib failed in a prior comparison at a dose of 500 milligrams because it didn't hit the primary endpoint, which was complete cytogenetic response at 12 months. In this study, at 12-month follow-up, there's still 82% on both arms on treatment, which is good. There's somewhat less attrition than what we have seen in other phase 3 trials. This is the key slide here, the response rates. MMR is the primary endpoint, and you see that bosutinib wins over imatinib with 47 versus 36.9%. Now, this is a remarkably high rate of MMR on imatinib, which is really higher than in other studies for reasons that we don't really understand at the moment. This is statistically significant. There are other endpoints of note as well, such as complete cytogenetic response, which is also superior for the experimental arm. As we've seen in some other studies, a lot of the gains made are in the high-risk people. So if you look at MMR at 12 months in high so-called risk patients, there is essentially a doubling of the rate compared to low-risk disease, where the differences are really borderline and not statistically significant. This is event-free survival, overall survival. MITT means molecular ITT group. So these are the people who can actually be followed by PCR, and you see that again, event-free survival is very, very good, just like in other phase 3 trials for both of the treatment arms, pointing to the fact that it's very hard to improve over what we have at the moment unless we go for other endpoints such as MMR or even complete molecular response. This transformation to accelerated phase and blast crisis, there's an important disclaimer here, and that is that really half of the patients who technically fulfilled progression criteria did so because they had a rise in basophils. So this is really pseudo progression, I would call that. This is just because you eliminate with some interventions predominantly non-basophil neutrophils, and so the basophil percentage hits 20 or 21%, and then so technically these patients are then progressing to accelerated phase, but of course that's not really the case, and fortunately all of these patients remained on trial and went on to have good responses. So all in all, that means really low transformation rates, indicating that whatever you do to these patients, if you keep them on treatment, the results are excellent. Treatment-free emergent adverse events, diarrhea, more frequent in bosutinib-treated patients, consistent with previously published results. Musculoskeletal pain, more heavily represented in the imatinib arm, and then liver function abnormalities, more represented in the bosutinib arm. So really very much consistent with what we had already known. Now, one thing that I really want to point out here is that the cardiovascular event rate is quite low in this trial. But I personally think that the final call is not made here because there is a higher rate in bosutinib-treated patients versus imatinib, and we need to follow these patients carefully over time to completely understand what the cardiovascular risk is with this third approved second-generation TKI. If you compare the result of this before trial with other phase 3 trial, it turns out that the MMR rate with any second-generation TKI sits at around 50% at 12 months. Imatinib between 30 and 40%, really high in this before trial for reasons unknown. If you look at MR 4.5, that data is not yet available to any significant degree from the before trial. You see that clearly the experimental arms, in this case nilotinib, in this case dasatinib, win over the imatinib. So I think very much confirmatory of previous data. So let's move on to the second scenario. So not frontline, but patients who relapse on first-line treatment. These are the currently approved TKIs, and I see that imatinib has a lot of liabilities in terms of single BCR-ABL mutations. Then second-generation TKIs cover in combination everything but T359, and then it's only ponatinib that has activity against this gatekeeper mutant. So I think an interesting development is an allosteric inhibitor of the ABL kinase. As you know, the currently available approved TKIs are all ATP competitive. They target the catalytic site of the kinase. However, ABL and as such BCR-ABL has an allosteric regulation site here at the base of the kinase. If a myristate residue or chain binds into this pocket, you re-establish an auto-inhibited conformation of the kinase. So I think nobody really expected that this would be fully functional in the transforming BCR-ABL protein as opposed to the native ABL, but it turns out it is. So if you stick in myristate here or a myristate mimetic, you can re-establish this auto-inhibition conformation. This is just, this is basic chemistry. You may remember that. So this is evidence for allosteric inhibition. It is really not dependent on the concentration of ATP that competes with the inhibitor, unlike in the classical TKIs. A very interesting feature of this compound is that it is highly specific. This is a cell line screen. And the red dots are BCR-ABL positive lines. And you see with ABL 001, you have literally no activity against non-BCR-ABL cell lines that are the blue ones over here. Whereas at the other extreme of the spectrum is ponatinib, where you have quite a bit of hits, even in lines that are not BCR-ABL positive. So that indicates a great deal of specificity. Mutations are generally covered, including T359. This is ABL 001 as asciminib. You see that it sits right in the middle here of the response spectrum. Mutations, on the other hand, that sit around the myristate binding pocket here in red confer resistance to asciminib, and so the expectation is that this might actually turn out to be an issue in clinical scenarios.